Hi everyone, it's Michelle Lyons back here again with another of my Meet the Expert series, and I'm absolutely delighted to have my learned colleague Grainne Donnelly talking today about one of my favourite topics, and one that's really kind of hot at the minute as well. And I had the privilege of hearing Grainne rehearse her presentation for the POGP conference a couple of weeks ago, and I thought we have to get this out into the wider world because she has to share her genius with the rest of us. So she agreed to come on and do a video chat. So hello Grainne, how are you? And if you'd like to introduce yourself, who you are, where you're from, where you work.
Okay, thanks for having me on, Michelle. I'm absolutely delighted to be here. So I'm Grainne Donnelly. I'm a physiotherapist based in lovely County Fermanagh, and I work in both the NHS and in private practice alongside my husband, who's also a physiotherapist. So basically, my background is as a pelvic health physiotherapist. I love treating all things to do with pelvic floor, pregnancy, postnatal, abdominal wall diastasis. Obviously, I love that. So that's what's got me here today.
Great stuff. And you just finished your postgrad in Bradford. So this is part of your grand finale with them.
Yes, it's right. So I really enjoyed my postgrad in Bradford over the last 18 months. A lot of work put in, but it was great. And I'm now delighted to be speaking at the POGP conference after that.
Brilliant, brilliant. Well, they're lucky to have you because I know what's in store for them. So we're going to give them a little taste today of what's coming up. One of the things that I really loved about your presentation, and there were many, was this strategy that you described of your PPP-RRLD strategy. And a lovely little acronym for remembering that was preventing pregnancy pressure, restores rectus, lessening diastasis. And I thought that was really, it's a great kind of overview of what we want to do as physios, both in pregnancy and postnatal. But I wonder if we could just break it down, because the PPP and the RR and the LD, they each stand for different things. So if we look at the first P, because I actually think this is the most important part of the equation, the first P is for person. And I really liked how you talked about, you have to listen to the person and find out what their story is. Do you want to just maybe take us through each element of that, maybe just briefly, so we can follow along?
Perfect, thank you, Michelle. And I'm really glad you liked it. The reason I came up with as I coined it, the triple P double RLD was because I've been doing a lot more teaching and workshops for other health professionals in terms of diastasis, and I wanted to work through a logical performa such that people could, I suppose, understand what they need to look at and what they need to consider for diastasis, because as we know, it's a lot more than just the gap, or as I hope we're developing and beginning to recognise. The first P that you've mentioned is for person, and I think this is one of the most important elements as well. Basically, we need to consider that lady in front of us and her journey, how she's got here today, why she's in our clinic. Is this a recent diastasis? Has she just had a baby and she's just been diagnosed? Or has she had this diastasis for many years? I know a lot of women coming into my clinic decide that they wanted to wait until they finish the family before they do anything about it. So you're starting to get an understanding of how long they've been living with it, maybe how long the issues with diastasis are building up. And also things like their baseline, because an elite athlete coming in looking to get back to sport as soon as possible is going to be very different from your average mum, or even the likes of myself coming in wanting to get back to normal day-to-day life. But most importantly with the person is the expectation, and I think we need to establish this from the offset.
Yeah, absolutely.
I don't know about you, Michelle, but a lot of women come to my clinic not so much for the functional elements initially. They come because of the aesthetics of diastasis, and that's the reason.
Yeah, absolutely. No woman, unless she's a pelvic floor physio, nobody really cares, apart from us, about the fascial integrity of the linea alba.
Yeah, I totally agree. So women come to my clinic for this reason, and I have the delight of treating them for the functional aspects of it, as well as, yes, if we can do something to improve the aesthetics, brilliant, I'm all for that.
Yeah.
But if someone's coming into me with, a pendule abdomen and they have a lot of loose skin there, and they're coming in because their main aim is, I want you to tighten up this skin. Yeah. Absolutely, I'm establishing, I cannot achieve that. So we need to establish from the offset whether physiotherapy can meet their expectations and start the educational component from there.
Yeah, absolutely. And I think, you know, sometimes we do have to talk about weight loss as part of the recovery journey as well, that we can't just do spot reduction, you know, and close that gap and then we're going to get back to a six-pack again. And I think, you know, it is about being realistic, but I mean, how many women do you feel that this gap, this diastasis, is a barrier for them, you know, participating in just general exercise, which could be part of a general overall wellness approach for them, both cosmetic and physiological and psychological too? Do you feel it's a barrier for women to getting back to exercise and sport again?
I actually do, and I think that Mr. Google has a lot to play for that. If people are looking up diastasis, and people are becoming a lot more aware of the term diastasis and a bit more aware of the fact that abdominal separation can happen after pregnancy.
Yeah.
And then they go onto the internet, and there's, you know yourself, there's a lot of misinformation out there, there's a lot of conflicting information out there, and it becomes very fear-inducing for this population. So I find a lot of women come because I'm not sure what I can do, but I know we need to do something to get rid of this tummy, is basically their objective. So I love taking the approach of enabling women and show them what they can do and what's safe to do, and empower them as such to resolve their own issues, basically.
Yeah, and I mean, I think that's why, Grainne, I really feel like you're kind of leading the change in physio, and particularly women's health physio, because I think two things. I think physios need to be better at in terms of general exercise prescription. I think we're quite good at zooming in and looking at local problems, but we have to remember that there is actually a woman attached to this body as well, and she has a life, hopefully, too. And, you know, how can we get her back? Because we know, don't we, that exercise is just so important in terms of global health markers, heart disease, diabetes, Alzheimer's, all those, the big issues, never mind bone health that so many perimenopausal women have to deal with. So I think just acknowledging that there could be some barriers towards exercise, that we can really kind of have this multi-pronged approach to getting her happy with her own body again, confident in exercising again, and getting her moving. Yeah, so I think I think it's the most important part of the equation. So I'm delighted to see somebody like you spearheading this. The second P then is for posture. Now, this is such a hot topic in our world at the minute, you know, like, what is good posture? Is there any such thing as good posture, and does posture matter? What do you think?
Right, Michelle. Well, this is a really interesting one when I was creating it, because as I've mentioned, my husband's a musculoskeletal physiotherapist, and sometimes we don't always completely agree with our approaches and things, and, you know, we get a bit of hot discussion on the go.
Nice.
But I think posture is a component to be looking at in terms of women with diastasis. Now, when I've been challenged in terms of does posture matter, because we know with some research with neck pain and low back pain, it has challenged any link between posture and these presentations. And also in terms of some of the studies that looked at lumbopelvic pain and dysfunction in relation to diastasis also found no correlation. Yep. However, my background, firstly as a condition management physiotherapist, I worked with long-term condition management for several years, and it was a very hands-off role, and it was very much under the biopsychosocial model of care. And when we were carrying out workshops with these ladies, we really focused on the, I suppose, the association that posture can have with a person's self-confidence and self-efficacy. And there's studies that have shown that poor postures do impact on that.
Yeah.
Because I know that one of the biggest reasons that women end up coming to my clinic is due to body image and lack of self-confidence. If I can affect self-confidence in terms of posture, well, that's exactly where I want to start.
Absolutely, absolutely. And do you think it matters from a mechanical perspective then, or do you think it's more from the mood, self-confidence, decreasing any sense of catastrophization about their body? Or do you think they're both important?
I think both. So I've mentioned in terms of, I do think that it has a psychological implication, and we all know if someone comes into a room and they're walking tall, it's usually a sense of confidence, whereas people coming in a bit shy, we know those presentations exist and we know what they mean. Yeah. But there has also been a 2018 study produced recently, which actually, I suppose, showed some correlation between poor posture, particularly anterior head carriage, and how that affects respiration, basically, forced vital capacity. And I'm going to talk about breathing as one of the components that we want to work through. So if I can do something to improve someone's breathing mechanics, well, that's another reason to address posture.
absolutely. And I think, I mean, I'm a big fan of generally of breathing.
Yeah.
But I mean, we know that breathing and continence and bowel health are much more connected to back pain in women than BMI or level of activity. So I think, we have to remember that there is a bio in biopsychosocial as well.
Mm-hmm.
And we just want to make sure the pendulum doesn't swing too far. And to acknowledge maybe that there isn't any one good posture, but what we want to make sure is that these women have a vast array of postures available to them, that they can move with ease throughout their lives, depending on what their demands are, I suppose. Would that be fair?
Absolutely. Yeah. And funny, to come back to the self-efficacy thing,
yeah.
Even in terms of if we can get someone, if someone can feel better about their body in terms of their posture, I think you can increase their compliance to rehab, because diastasis rehab is not a quick fix. No. You need to have compliance, so I think that's a major issue as well.
I think that's absolutely huge. The next P is patterns. So do you want to tell us what you mean by patterns with this regard?
Patterns can mean multiple things really, but my big go-to with patterns is, with diastasis I tend to find a lot of women, whether they've been living with diastasis for a while or not, but they tend to go into holding patterns. And what I mean by this is you often see a lot of upper abdominal gripping. Do you know what I mean by that, Michelle?
Absolutely. Yeah. So those overactive, maybe external obliques just holding on for dear life.
Absolutely, and a lot of women don't realise they're doing this. So I have the extremes. I have the women who come in who have a holding pattern. You can really see nearly an indent in their upper abdominal wall. You can see it gripping. You can see them talk. Yeah, and even anything when they go to talk, or even any sort of increased breath, it's a lot of upper abdominal recruitment.
Absolutely.
But I also have the women who I call them the serial tummy holders, because diastasis does impact and give us a bit of a pendular abdomen, and because social media these days has created this ridiculous idea that women have this flat abdomen and created such big pressures, we become into chronic tummy holders. We suck in, it just becomes the norm.
Yeah, absolutely.
And so basically we want to identify, is there any patterns going on, because I think that's a really important place to be starting. You need to stop these holding patterns before you can then build up and strengthen and recruit and teach people to recruit in the right way.
Absolutely.
I suppose my thoughts on recruitment patterns, I'm not completely OCD that there has to be this muscle has to fire before that muscle, but I do think that people should be able to connect their deep core, and they should be able to get that co-contraction with pelvic floor and transverse abdominis. Oftentimes the upper abdominal grippers don't do this. They go for a more superficial and global recruitment.
Yeah, absolutely. And I think as well, if you are super grippy with those upper abdominals, that's going to have an effect on your breathing again, and thoracic mobility. Sometimes I find as well that if they're not wearing a well-fitted bra, that can actually be a big driver, can't do that, like upper abdominal tension too. So I think sometimes, we want to remember that, again, like you said, to look at the whole person, that we don't forget our bread and butter skills as physios, coming from that ortho MSK perspective, that we actually look at things like thoracic mobility, bring that into the mix as well. But honestly, I find like bra fitting is a huge deal in that whole pregnancy, but postnatally particularly, and then again when women are going through perimenopause. And I think it's often overlooked in terms of abdominal pelvic function. So yeah, it's another really important element, which kind of feeds us nicely into you talking about respiration.
Yes, so respiration's the next part of my triple P RRLD, and we've talked about respiration is so important in all areas of pelvic health. It's so important in terms of physio in general, but as pelvic health physios, I think everyone generally appreciates the importance of breathing. And yeah, so basically one of the open lines, I actually enrolled into your Breathe Better course, Michelle, and one of the opening lines you say in it is basically that we can utilize the diaphragm to manage intra-abdominal pressure. And that's one of the biggest things that patients with diastasis struggle with. It's that intra-abdominal pressure management. So that's why you tend to find that the dome or that the abdominal midline sinks in with certain activities.
Absolutely.
What better than to utilize our own bodily system to help manage intra-abdominal pressure than anything else? So that really resonated with me, and I thought it was brilliant.
Great.
But yes, because we know that the diaphragm and the abdominal wall and the pelvic floor are intimately linked, and that they work in a nice synergy together, dysfunction at one can affect dysfunction at the others, and they can all relate. So it's so important to re-establish that nice synergy between breathing, abdominal wall and pelvic floor.
Definitely. And I think, you know, I did an interview a couple of months ago with one of our colleagues, Susan Clinton, who'll be coming over to talk at Women on Fire next year. And we talked about that, how, you know, sometimes women can get into the habit of breath holding as a way of giving that internal stability. And, you know, we were talking about how it's important to teach women how to use their glottis rather, you know, or to use their glutes, not breath holding with that closed glottis in terms of pressure management in the center of the body. And I think sometimes we do that without even realizing it, don't we? So it's habit some of the time. And I think just bringing that awareness and mindfulness almost to strategies and patterns, like you were saying. So, I mean, again, like I'm completely fangirling over your stuff here, but I really love how one just kind of flows into the other, you know, because it's all so interrelated. And of course, then respiration, then we move on and we talk a little bit more about the rib cage, which I know we've kind of touched on a wee bit. Is there anything else that you think merits discussing about the rib cage?
Yeah, and again, I had to give the rib cage section on its own. You know, I could have grouped it in, but no, it deserved a section. And once you're there considering respiration, you're already looking at the rib cage. And I tend to find, again, it depends on if we've got these overactive patterns or not, but the rib cage can flare a lot of times with these women. So in order to achieve a loading task for the abdomen, something as simple as even chin to chest, you get this big flaring of the ribs.
Yeah.
And yes, they can achieve the task by doing this, but is this optimal and is this going to help them rehabilitate their diastasis? No, I think we need to re-establish how to stabilize that rib cage.
Definitely.
Now we have to remember that the rib cage goes up and out in pregnancy. Anyway, and again, that's where you talked about bra fitting, and I think that is such an important point, Michelle, because I think a lot of women don't realize that their bra size might change in pregnancy and that we have to be remeasuring.
Absolutely.
And it might not always come back into pre-pregnancy straight away, especially if people are in these flare and holding patterns. But yes, I look at the infrasternal angle and I get an idea of whether it increases with flaring, or sometimes if the external obliques are a wee bit overactive, you can actually get a kind of the infrasternal angle coming together a bit more. So I think considering that, and I think it fits in with the posture as well. So you're kind of linking those elements.
Absolutely, and even just to consider as well the way the rib cage, you know, it is attached to the thoracic spine. So, you know, to think about, you know, what's their thoracic rotation like, what's their thoracic extension like, because usually thoracic flexion is not much of a problem for most people, but especially for postnatal women and even perimenopausal women. But I think to remember again that we are working on global, you know, kind of that dynamic stability and mobility in around the range, and just people how to get used to their bodies again, like particularly in that postnatal period, because, you know, it takes 9 months to grow the baby, and then whatever the exit route is, you know, there's a substantial amount of recovery and remodeling that has to go on, and I think that's both a good thing and a bad thing. You know, we know we've got that maybe 1.5, 2-year window really of remodeling once you've had your baby. And I think just to, like, you know, I just like to tell women, as long as you're still above ground and you're still drawing breath, there's always room for improvement.
Absolutely. Love that.
It's one of those things, but I think just, again, really just getting women moving and comfortable in their own bodies again, I think is really, really important. And I think kind of the breathing is a really good gateway, because it's so important from an emotional perspective, but just from a functional, structural perspective as well. If we're looking a little bit further south, you know, when we're looking at this through the lens of diastasis, and you start, then your first L is about the load, you know, so if you could talk a little bit about that, like things like managing, you know, looking out for hernias or dealing with constipation, things like that, would they fall under that category?
They would, but in fact I did give hernias a section in a sense on its own, so we'll come on to that. But the load for me is really important. All of them are really important, but I particularly like the load because this is where we as physiotherapists get to establish what level of exercise this lady is ready for and able to achieve. And it tells you a lot in terms of assessment, but also in terms of your exercise prescription. So I think that everybody with diastasis needs to have an individualized program. There's no one size fits all, and that's the issue with a lot of stuff out there on the internet, unfortunately. I've been around the block, I've tried a few things, and I've evolved to where I am today as a result of this. But so in terms of load, we want to see what simple abdominal loading tasks, what happens with them when we get someone to do a chin to chest, what happens when we get someone to do an active straight leg raise to 30 degrees. Again, we're looking out, do they flare, do they dome at the abdominal midline, does it sink? and how are they managing that abdominal pressure. So I would start off with very low level exercises. A lot of them tend to be Pilates style exercises, and I see how someone is managing that. And what I'm hoping to do, I'm really stacking up the load as I go along to the point where I find, right, that's your limit. You're starting to now do things like arch in the upper back because you can't stabilize. So I really use load to identify where we're at. However, we can't forget about pelvic floor. So,
I'm so glad you said that.
Yes. So a diastasis becomes very focused on the abdominal wall and the abdominal midline, but we have to remember that we're pelvic health physiotherapists. We're well placed to consider and assess the pelvic floor. And my worry is that if someone has a significant diastasis and maybe isn't managing their abdominal pressures well, or has compensatory holding patterns or movements, what is this doing to the pelvic floor? Now, the evidence for this is quite conflicted, as you know, Michelle. We've discussed this before. We have older studies that were more retrospective in their nature that say that yes, there's a link between diastasis and pelvic floor dysfunction. And we have newer studies, like Carrie Bow's study that was prospective in nature and had a good sample size. However, and it totally refuted any link between diastasis and pelvic floor dysfunction. I would question whether I suppose exposure to diastasis over a longer time period may predispose people to pelvic floor dysfunction.
Yeah.
Because these were all first-time mums, and they were followed up to 1 year.
Yeah. I think it'd be really interesting to find out what happens at 5 or 10 years down the line. And I think as well, you know, I mean, I remember looking at that Carrie Bow study when it came out first and just being, you know, it just challenged everything that I was thinking. But, you know, you can kind of see the logic, because if you have that gap in the abdominal wall, you know, the pressure has somewhere to go, so it's not going down and out. So yeah, you can kind of see the logic as to why maybe there isn't that initial rise in prolapse that you'd expect. But again, then are we ending up with a situation where we get overactivity towards that end of the spectrum with dysfunction of the pelvic floor muscles as time goes on, like you said, and maybe we have subsequent pregnancies or constipation or heavy lifting or return to high level sport. So I think it's still very much an area for discussion, but I generally would say clinically, and I'd love to know what your thoughts are on this, clinically, if somebody has a diastasis, they almost always have some sort of pelvic floor issue going on there, or some sort of back pain or restriction in function, I think would be kind of just an overall kind of bucket term, I suppose, for it. So I often find that, you know, if you can get a little bit more awareness of the diastasis, the other issues tend to follow along. Would you find that as well, or what's your experience?
Absolutely, and that's why I suppose Carrie Bow study really challenged me too, because clinically I do find it, and then I have to take a step back and think, right, okay, am I looking to find things? But no, I find that there is an implication, and you've mentioned even overactivity, and I do find it, particularly with the abdominal grippers, I'm nearly thinking what's going on with their pelvic floor, because
and also their TMJs.
Oh, it's all linked.
Yeah.
Those are the similar patients who, when you're getting to do a chin to chest, become quite neck, and you know, they become grippers to get up.
Mastoids are just jumping out. Yeah, absolutely.
Absolutely. But the other thing is, I was interested about Carrie Bow's study because it didn't look in terms of pelvic floor dysfunction, in terms of sexual dysfunction or myofascial pain. So that element wasn't investigated, so to speak.
Yeah.
The prolapse, I think it was only grade 2 on the POPQ that was classified. So, you know, could there have been earlier indications of prolapse, or maybe that's not that significant?
Who knows?
Who knows?
As they love to say in studies, further research is needed.
Yes.
On this topic.
Yeah. But I think,
go ahead.
Sorry, one thing I was going to highlight is that it's very hard as time goes on in any studies following up, because there's so many confounding variables in terms of what other reasons women get prolapse and pelvic floor dysfunction. Are we ever going to get an answer to this question?
Probably not.
You know?
Probably not. Did you want to say something about hernias? Because I know you felt like they deserved a special, an honourable mention.
So the last letter is D on my little PPP-RRLD, and it stands for defects. And in terms of defects, we're dealing with a population, postpartum women, they're higher risk of abdominal hernias, like umbilical hernias. And oftentimes I find that with diastasis that their risk factors are increased. They've got thinning of the connective tissue, they're possibly more likely for that to be perforated. we're not diagnostic in terms of our ability. Yes, you might have an indication that someone has an umbilical hernia, but I think it's for you to refer on and signpost for someone to get that looked into. I did spend a morning with Dr. Sorensen in London. I was a plastic surgeon, and I was very interested to see his take on, I suppose, his surgical repairs of diastasis. But we discussed hernias, and he said that obviously because umbilical hernias are not likely, or they're not as high risk for strangulation, that they generally don't do anything with them unless they're problematic.
Okay.
But that's not my decision to make. So I tend to, if I think someone has a abdominal hernia, I'm looking right back to the GP to get that looked into.
Absolutely, because what if something happened, you know? Yeah, I think that's absolutely that's spot on. And in terms of managing that defect, do you feel like, I mean, have you come across any research looking at the role of nutrition, for example, in managing that? And maybe even the other end of the spectrum, can constipation, chronic constipation strain, can that add to the defect?
Completely. I find chronic constipation is one of the biggest things, and it's something we do regularly, ideally every day or up to 3 times a week. You're hoping that people are going to the toilet, and that's quite a lot. If it's a task that's ongoing. So if people have poor defecation dynamics and poor, I suppose, biomechanics of emptying the bowel, and they're you know, it's a lot of bearing down and straining. Already, if I kind of bear down, I can feel that pressure in my abdominal wall. So we know that, and when I explain this to my diastasis clients, they go home and they're looking to implement some of the defecation dynamics that I've advised them on, and they come back being like, I felt my tummy, and I was aware it actually gets pendular when I'm, you know, if I don't think about that, it gets pendular when I'm trying to empty the bowel. So that's something that's continuously straining. So absolutely, that's so important.
And can nutrition play? I mean, if we go upstream from the constipation, do you feel like, is there any evidence to support nutrition in terms of healing the collagen? Can collagen regenerate?
Well, we do know that collagen can regenerate. We do know that nutrition can facilitate this. I'm not aware of any research specific to diastasis, and this is where I'm looking to, but I'm really interested in this area, and I'm really interested actually to see what you say about this. But we know that even in terms of postnatal health, that we want to help our women have a diet that nourishes them in terms of recovery. You know, you used to hear things about bone broth and obviously getting your fruit and veg and your natural minerals and water, all that thing is important. But my big thing with processed foods and with, I suppose, diets that aren't as healthy, so to speak, that a lot of women get abdominal bloating anyway. So I know myself, certain foods would make me bloat.
Yeah.
If we're going to eat foods that make us bloat, and then we have a diastasis, you're stretching, you're encouraging stretching of that abdominal midline. So I think that that's another factor that plays a part.
Yeah, that's a really good point. Yeah.
What's your thoughts on nutrition?
Yeah, I mean, I think, you know, the Mediterranean diet just seems to be so good for everything, you know, these days. But I think if you are looking at a multicolored, high fruit and vegetable intake diet with lots of your good essential fats, you know, your extra virgin olive oil, your nuts, your seeds, you're taking in your fermented foods, your dark green leafy vegetables. You know, we do know that vitamin C and good hydration, you know, are two of the biggest building blocks, I suppose, for soft tissue repair, whether we're talking about post-athletic injury or post-childbirth. So I sometimes think, you know, we can sometimes rush after the bright new shiny thing without kind of looking at getting the basics of good nutrition right. Like, I mean, bone broth is so trendy at the minute. Like, my granny just used to call it stock. Like, it was just what you did with the leftovers of the Sunday roast afterwards, you know. But now, you know, it's you know, we know there's lots of nutrients available to that. Is there a direct link between taking in collagen and it going magically to the area that needs repair? I don't know. But I think the best thing that we can do is provide as nutritious an environment. If you can control your controllables in terms of staying away from highly processed foods, staying away from added sugar, you know, we know that fruit and vegetables are very high in antioxidants and phytonutrients. So I think that's probably our best bet to go with. And then, you know, throwing in some stock or some bone broth and fermented foods into the mix as well. But it's also what agrees with you as well, you know.
Yes.
I think so many people feel they have to, you know, they have to eat an avocado every day. This is a question that came up in one of the groups, but I don't like them and they make me feel ill. So how am I going to eat them? I'm like, don't, you know, just don't eat them then. Because
but this is what I mean. In terms of we're dealing with a population too sometimes that they're so vulnerable to what's put out there on the internet, and that's what sometimes it's the common sense element of things just needs to be brought together. You need to have that discussion with them, and that's why they need individual management.
That's just it. Like, I mean, I think there are certain universal truths, but what I see a lot of happening now in the field of nutrition and health and wellness is everyone's very focused on protein intake. I'd be far more interested in you upping your fiber intake in the form of cooked vegetables than I would be obsessing about your protein and supplementing with protein powders, or, you know, because they're very highly processed. Like, go cook up some broccoli and have that, or make a big bowl of stew or something like that and have that in, and it's probably going to be a far more use to you and probably far cheaper as well, you know. So I just think eating well doesn't have to be complicated.
It doesn't, and as you said, like, eating well is not just in terms of diastasis. We know it has bowel health, we know it has bladder health, we know it has, you know, if we go to anything, eating well is an answer.
Health, yeah, everything. Yeah. And I just think as well, for, you know, for women in that postnatal period, I just think once that baby's on the outside world, postnatal women are so neglected, you know, and just to kind of give them good self-care strategies at this stage that will carry them through, because, you know, it's often when women hit menopause that we see a lot of the after effects of obstetric events that maybe happened 20 years ago. But that's when we start to see a lot, you know, a big spike in the pelvic floor dysfunction realm, you know, prolapse, incontinence, but bone health and heart health. And I just think nutrition is so important for all of those. I will say that the two things that I think probably most postnatal women could benefit from taking in supplement form, and I don't say this about much, but I think almost everybody is vitamin D deficient. And we know vitamin D is really important for soft tissue repair, but also for pelvic floor dysfunction. You know, there's some good research looking at that. And I just think to make sure that you're getting in enough of those omega-3s as well, because they're just so anti-inflammatory, and bone health and heart health and brain health and all those issues that women are going to have to deal with down the line. But like yourself, I just don't think it has to be complicated. You know, I think sometimes we like to make things hard for ourselves. You know what I mean.
I do.
So if we put all that together, you know, I've two kind of final questions just to kind of wrap it up. Can we prevent diastasis? Will be the first question, or is everybody going to get one?
Well, we know from, well, the prevalence factors in the research, again, is another debate ongoing, but more recent research has identified that 100% of women by gestation 35 weeks have it. So to me, I like that. I like the idea that it's a natural occurring process. Some degree of separation is normal. That tissue's there for a reason. Absolutely. And so I want to take the fear away from diastasis and the focus of, you know, people obsessing over a gap. So it, you know what I mean? So I think that's really important. I think some people will get some separation. In terms of prevention, I still think that there are some strategies that can be put in place, and this is something that I'm really looking forward to kind of working on. In terms of, like, again, you talked about constipation postnatally, but what about during pregnancy? We know that people are on iron supplements, they get constipated. That's another thing that's putting pressure against that abdominal wall. Is it encouraging excessive separation at that midline? Is it encouraging poor strategies of thinking in postnatal and stop resolution and natural resolution of diastasis? All these questions in play. Does posture have any implication? I'm not saying that the Patrick is shit, but does posture ultimately have any implication in it? And yeah, in terms of everything we work through basically could be applied prenatally to think, how are they breathing? How are they holding?
Yeah. And I think just general mobility as well, because you know, there are a couple of schools of thought that you shouldn't exercise in 4-point kneeling in pregnancy because the weight of the baby is going to encourage separation. Or will it be that if you're doing that consistently throughout your pregnancy, is that actually going to encourage regular sarcomere lengthening and will actually make it more likely to recover afterwards? And I don't think, do we have any definitive answers on that?
I've been looking into, this is something that I've been quite interested in, and even looking in at the linea alba and the makeup of the linea alba in terms of people with diastasis and without diastasis. And a recent study, we can publish studies below this afterward, but a recent study identified that the clients with diastasis had lower levels of type 1 and type 3 collagen in the linea alba, and we know that type 3 collagen is that one that's good for anything that has to expand any area. So if we think of a pregnant lady, obviously our abdominal wall needs to expand. If someone has lower level or type 3 levels of collagen, are they already at a higher risk of diastasis? So there's less likelihood of that maybe recurring back. And is that something to do with genetics and a natural risk? Can we do something about that? Or what I also looked at was, there was a study to do with rats, and it was actually prolonged stretching of tibialis anterior, I think, in rat models. And it showed that in these rat models, they actually produced or laid down more type 3 collagen. So I'm just more thinking of what you're saying about 4-point kneeling. Is it a case that if we expose people to certain things that they actually load down more of the type of collagen that we need, and can we influence this? We don't know that at the minute, and that's something I'm really interested in, because if we could affect the, I suppose, the collagen makeup of the linea alba, physiotherapists, oh my goodness, we're well placed to be in a position to be doing things here.
So there's your PhD.
Oh.
To wrap it all up, what are the important things in terms of rehabbing a diastasis? What are the key things, if you were to give your top 3 tips for diastasis recovery? What do you think it's important for us to focus on? Oh, I'm after losing you, I think, a little bit. I'm just going to pause it. Oh,
first of all,
you're back.
Before we get in, oh.
No, you froze there for a minute, but you're back now.
Can you hear me? Yeah.
I can hear you.
So the first thing I like to focus on is, okay, you can see me?
You're just not moving. So I'll tell you, just give me 1 second. There we go, we're back again. So
okay, so yeah.
You're going to talk about your top 3 issues or features of good diastasis rehab.
Right. First and foremost, before we jump into exercise and actual rehab prescription, I like to evaluate that person's day-to-day life, look at their story, look at what they're doing, how many kids they're lifting and hauling around, how they're emptying their bowels, what they're eating, because you can do all the rehab in the world, but if you don't correct the basics of what they're doing every day, it's not going to happen. Okay?
Couldn't agree with you more.
2, I like to, in terms of exercise prescription, prescribe the maximum loading exercises that person's fit for at that stage, and to revisit that at each session to increase load.
Brilliant.
I think we can get into a habit of erring on the side of caution and giving all exercise on the back, and people find it boring, it's very disempowering. So I'm big into getting functional and seeing them progress so that they feel, and even doing things like resistance training, and I progress people onto weights then, because they love it.
But you're like, that's their real life. You know, they're going to be lifting up bags of shopping or babies or pulling wet clothes out of a washing machine. And I think that has been a criticism of us as physios, and well justified in the past, that we're too conservative maybe with our exercise prescription. So I'm delighted to hear that. So I think as long as you can breathe while you're doing the exercise, you're not doming and you're not leaking, have at it.
And the other thing I like in terms of my approach to this is you have to educate. You have to have that client understand why it is we're taking the approach we're taking, what realistic expectations are available, you know, and what why we're doing certain exercises. What, you know, I'm trying to think what I was even saying there, but sorry, Michelle, I've lost my train of thought.
You're explaining to the woman why you're doing what you're doing, and maybe just getting good buy-in for your logic.
Yes, so it's more for compliance, because diastasis rehab can be slow and it's not a quick fix, and women want quick fixes. It's really unfortunate, but so you have to get them on board and to comply, because the hard work does pay off. Absolutely.
And I think, you know, just starting low level, like you're saying, maybe getting, if you look at the work that, you know, Diane Lee and Paul Hodges have put out, you know, getting that pre-activation of the pelvic floor, of the deep abdominals with good diaphragmatic integration, and then loading on to that. I think that particular piece of research was a huge step forward for us. And I think that it did raise some questions as well, you know, and we could go down the rabbit hole of distortion index and all the rest of it. But I think, you know, for me, all roads lead to function. And I think, you know, to have an exercise strategy that's functional, but, you know, that actually is a bit fun to do as well, is no harm, and that's challenging to do. Because like you're saying, like, this is where we live our lives, kind of upright and moving around, and to tell somebody to go and lie down and do 3 sets of 10 exercises, like yourself, I mean, I'd love to be able to lie down 3 times a day to exercise, but who has time?
Not happen.
You know, so I think I really like your approach is to get women up and moving and active and back to what they want to do again.
Yeah.
you know.
Funny, at that, I have ladies who, like one of my more recent clients is back at CrossFit. That was her goal, so I had to help her achieve that. Rather than disabling and saying you can't do that, she's going to go back to CrossFit anyway, so I had to enable it.
Absolutely. But you know, so there's no such thing really as a bad exercise. It's all about how you do it, isn't it? Technique is everything, you know, and getting those strategies in place, and then explaining why you might want to just kind of regress to progress, you know, back to where you want to be again. But I think if you actually treat people like human beings and explain things to them, you know, I think it goes an awful long way. Shockingly. Grainne, where can people find you? I know I'm POGP conference in November?
The start of October, so 2 weeks time.
Very good.
Yes, so I'll be at the POGP conference, and I'm online at absolute.physio is my handle for most things, so you know, you can follow me on social media. I usually like to talk about things to do with diastasis, so I'm always up for discussions about it too. And I'm based in beautiful County Fermanagh in Northern Ireland, if anyone ever wants to connect.
Brilliant. Grainne, I can't thank you enough. So many pearls of wisdom and logic and evidence. And like I said, I just think the future of physiotherapy is bright.
Oh, thank you. And thank you so much, Michelle. And thank you for all your help. And I really appreciated you hearing my presentation, because it gave me a lot of confidence after that. So thank you.
It was an absolute pleasure. The POGP crowd don't know what they're in for.
Gosh.
We'll talk to you soon, Grainne.
Okay.